Elbow procedures. Published by WordPress.com. Elbow arthrodesis, elbow fusion. Definition. Elbow arthrodesis is a surgical procedure that involves the fusion of the humerus and ulna, or radius, to create a stable, pain-free joint in cases where total elbow arthroplasty is not a viable option. It eliminates motion but provides a strong, functional upper limb for activities that do not require significant elbow mobility. 1. Indications. A. Post-traumatic conditions. Severe post-traumatic arthritis with pain and instability. Failed total elbow arthroplasty, T, with infection or mechanical failure. Chronic instability due to severe ligamentous injury. B. Infectious and tumor-related indications. Chronic osteomyelitis or septic arthritis unresponsive to treatment. Resection for tumors involving the elbow joint. C. Neuromuscular conditions. Brachial plexus injuries with a flail elbow and functional hand. Post-polio syndrome in select cases. D. Other indications. Severe elbow pain in young, high-demand patients where T is contraindicated. 2. Contraindications. Bilateral elbow involvement, as fusion severely limits functional use. Functional hand impairment, as elbow mobility is essential for hand use. Inadequate bone stock, for stable fixation. Non-functional shoulder or wrist, fusion requires compensatory movement. 3. Optimal elbow fusion position. The functional position depends on the patient's occupation and dominant hand. Unilateral fusion, dominant hand, 90 degrees flexion, best balance for activities of daily living. Unilateral fusion, non-dominant hand, 100 degrees to 110 degrees flexion, better for personal care tasks. Bilateral fusion, typically one elbow at 90 degrees and the other at 110 degrees. Pronation and supination are dictated by the forearm's position at the time of fusion. The wrist and shoulder must compensate for movement loss. 4. Surgical techniques. A. Preoperative considerations. Imaging. X-rays, CT scans for bone quality and alignment assessment. Infection clearance. If infection is present, staged surgery with antibiotic therapy is needed. B. Surgical approaches. Posterior approach, most commonly used, provides good access. Lateral approach, alternative if the posterior approach is compromised. C. Steps of the procedure. 1. Anesthesia and positioning. General or regional anesthesia. Patient in lateral decubitus or prone for better exposure. 2. Exposure. Midline posterior incision. Ulnar nerve identification and transposition if needed. 3. Joint preparation. Removal of cartilage from the humerulnar joint to allow bony fusion. Decortication of joint surfaces to promote fusion. Bone grafting if necessary, autograft from iliac crest or allograft. 4. Fixation techniques. Plate fixation. Dual plate fixation, medial and lateral, for added stability. Intramedullary fixation, IM rod, less common but useful in select cases. External fixation, rarely used, reserved for infected cases needing gradual compression. And 5. Soft tissue management and closure. Secure wound closure. Drain placement if needed. 5. Postoperative care. Immobilization. Long arm cast or splint for 6 to 8 weeks. Weight-bearing restrictions. No heavy lifting for at least 3 months. Physical therapy. Focuses on shoulder and wrist mobility. Radiographic follow-up, to assess fusion progress. 6. Complications. Non-union or delayed union, especially in cases of poor bone stock or infection. Infection, common in post-septic cases. Ulnar nerve dysfunction, if handling during surgery is excessive. Fracture of the fused segment, rare but can occur with high impact. Shoulder and wrist overuse syndromes, due to compensatory movement. 7. Functional outcomes. Stable, pain-free joint for weight-bearing tasks. Limited functional range, useful for pushing, lifting but restricts reaching. Increased dependence on shoulder and wrist mobility for daily tasks. better suited for unilateral cases where the contralateral arm provides mobility.